All right, let's continue with our acquired neurogenic communication disorders. We'll move on. Well, I guess I should point out first, this is this is a lecture that usually when I do on ground is a guest lecture from Hala Alatik. She's a master's student. Well, actually, that's not true. She's a PhD student in our department. She was really busy this summer, though, and since my background is psychology, it was an easy one to take over. All right, so we have talked about these in the last section, so I'm going to skip over this mostly. These are circled here because these are the two that we're mostly talking about in this lecture: stroke and brain trauma. So, for stroke, most of you probably know what stroke is, but essentially it's a disruption of blood flow. There's two different ways that the blood flow can be disrupted, but we're going to talk about that in a second. The pictures are kind of gross, so if you don't like that kind of thing, this is your warning. All right, so almost 800,000 people have a stroke every year in the U.S. It's a lot, right? Most of these are age-related. Not all of them, of course. I mean, there's a lot of times you'll hear about younger people having a stroke. It's a little bit more unusual, for sure, but it's certainly not only the older population that are having strokes. Drug use can lead to stroke. Over-exercise can lead to stroke. Other medical conditions can lead to stroke. Sometimes it just happens. And then also it can be age-related. So there's a large population that will experience a stroke. A lot of the people that experience stroke also experience some lingering symptoms. In fact, it's like it says here, it's the leading cause of a long-term disability is stroke. And I mean, one of the reasons for that is just because it's so prevalent. 800,000 cases a year is a lot, and then also it's usually affects the brain, and so because of that, that's a very delicate instrument. So that's usually going to lead to some sort of long-term impairment, possibly, for the rest of that person's life. Sometimes people can come out of it. In fact, so I don't freak you out, I want to tell you a story, a really great story. There was a professor. I don't know if he's still a professor now. I lost touch with him, but he was in the kinesiology department. This was back when the kinesiology department was its own department. Now it is under, I think for a while it kind of like went away and it wasn't a thing, and then now it's back under College of Health Solutions, just like us. But at that time it wasn't. It was its own department. Anyway, this instructor had a stroke, and after his stroke he had a lot of paralysis. There was some speech trouble. There was a lot of problems with one side. I don't remember which one. One side of his... when I say speech problems, I don't think he had cognitive speech problems. This is kind of like what we talked about last time. I think it was paralysis of the effectors. So I don't think anything speech-related cognitively was affected. It was just, the actual musculature that was affected. And that kind of went along with also the paralysis in his hands and arms. Well, what he did was, when he got good enough to get out of the hospital, he just went out and started shooting free throws. And he couldn't quite get them. At first they wouldn't go far enough. They'd go really far to the right, I think, instead of, dead on like he was shooting. And so over time he would just correct it. He just worked to correct it, just kept shooting these free throws until he was back to where he was. And somehow doing that helped the other problems. So remember, it was all paralysis. I don't think that there were necessarily cognitive deficits, but shooting the free throws, he said, actually helped all the speech problems. You talk to him now, and you wouldn't know that there's anything wrong. The speech is not hindered. His walking gait is fine. Use of both arms is fine. In fact, he plays basketball before COVID, he played basketball every week still, I think. And, he seems fine. So it's not every time. If you know somebody that has a stroke, if your grandparents or parents or yourself has a stroke, or you're worried about it, it's not every time. It is a leading cause of long-term disability, but there's a decent chance that it doesn't lead to that. However, a lot of people who do have strokes end up with some form of language impairment. I believe that this takes into account also those purely motoric speech impairments. This figure, the 60%. So the professor that I was telling you about, he would qualify for that. It would, seem like he's would be one of those people with speech and language problems. Clearly, there are some. The speech problems are a little bit higher, and you're going to see them in the rest of this lecture. There's definitely a better prognosis on the ones that are just paralysis versus the ones that are more cognitive level, more more phonological issues. So here's our two different types of stroke. We have occlusive or ischemic and hemorrhagic. And the ischemic, which is also called occlusive, like I said, which should kind of cue you into what's going on there, is the blood flow is occluded by something. So maybe there's a clot or something, and that causes blood flow to not go to the rest of, following the rest of that, the vessel to the brain that it should serve. You can kind of see that here. This is showing that there should be blood flowing along this vessel, and it should be serving all of the rest of these two lobes, this part of the temporal lobe and this part of the parietal lobe here. It isn't, and so you would end up with some, kind of death of that tissue there because it's not getting oxygenated blood. A hemorrhagic stroke, on the other hand, the blood is going sort of to these regions because you've actually blown out the artery and there's a bleed. So there's a couple different things that happen with these. So obviously one is an occlusion, one is active bleeding. The artery has opened and it's bleeding. It is harder for the surgeons when you bring somebody in with a hemorrhagic stroke. It's really hard for them to figure out where the actual problem is. And that's because there's so much blood. The brain has a lot of cavities and all these different folds and everything in here that they'll have to check to make sure where it's coming from. So if they can find it quickly, that's great, but they can't always find the site of the problem quickly. And the longer it takes them to find where the problem is, the worse the problem is because they can't find it. And if the blood is flowing out, it is probably not flowing to the regions beyond the site of the break. That's not necessarily always the case. You can have some that are hemorrhagic and some blood does a small amount is able to still get to, say, down in this area. So let's say the break is here, the hemorrhage is around here, the blood flow is coming out. A little bit could continue traveling on, and that person would have a good prognosis. That kind of depends on the size of the hemorrhage. If it's, a really large hemorrhage, the blood is experiencing, it would be easier for it to leave the vessel entirely than to continue in the vessel. So then you would expect it would be kind of like an ischemic hemorrhage where no blood is getting past the site of the bleed, and then it's really hard to find the bleed. With an ischemic hemorrhage, however, it's really easy to figure out where the hemorrhage actually is. You can do imaging different types of imaging, which you see here. These are two different kinds of, well, it's the same kind of image, two different kind of problems. You can use this, you can see where the blood is not going in the brain very easily. This is an MRI. MRI shows you blood flow in the brain, and this will show you exactly where the blood isn't going. If you do something called diffusion tensor imaging, or DTI, it can actually show you the flow of blood too. So you can actually look at you can pair this up with DTI, and what it would do is it would put little kind of spaghetti, like multicolored neon spaghetti strands on top of this, and it would show you where the blood is going. So if you pair up MRI with DTI, you can really tell where the ischemic blockage is. Now, this hemorrhagic one over here, it's kind of like you got a blackout, like an information blackout, right? Because there's blood everywhere. So if MRI is showing us blood oxygen levels, well, when there's blood everywhere, you basically can't see anything. And you can do DTI, but if blood is flowing everywhere, you can't even do DTI. So that's kind of a problem. It is possible that modern versions of DTI could help this, but I haven't seen research on that. I know early DTI didn't help a lot with that, but it could possibly help with the hemorrhagic. I'm not sure. Either way, though, the basic fMRI image, you can still see this shows no reflectivity. But that means that you can still kind of see the structures in there. You can see where blood goes to. See how there's this little, this is a large vein. I say little, and really it is little, but in this picture it's largish, right? So you can see that there's blood going here, and then it stops, and it should be serving the rest of the brain. It's not. So you found the source of your blockage. Here, you can't see anything. There's blood everywhere. Okay, I think the next slide is the one with the pictures that you might be sensitive to. So this is the end of the warning. Oh, whoops, nope. Sorry. just keep freaking you out, never quite getting there. So the hemorrhagic goes along with an aneurysm. And an aneurysm is actually like where the artery is bulging. So you can have an aneurysm where you have a swelling of an artery, and it may hemorrhage at some point. This is why people go in. My aunt actually had a couple aneurysms, so they'll notice these aneurysms, these swellings, and they'll go in and kind of cauterize the area because it's a weak point in the artery. It could hemorrhage at some point. If it does, it's not going to be good. So they'll cauterize that and hope to enhance the structure of the vein at that of the vessel at that point. Okay, here we go. So this is what an ischemic attack looks like. You can see that the brain here that wasn't being served with blood has decayed. It doesn't get oxygenated blood. It's not continuing to be alive, and so it decays. And then this is what you get. Now the hemorrhagic, you can see that there's blood everywhere. So if we were to look in here, we know that somebody's having a stroke. We get in, we look. You can't tell. If there's blood here. Is the break here? There's blood here. Is that where the hemorrhage is? There's blood back here. There's blood over here. It's really hard to figure out. And the longer that it takes to find it, the more blood gets into the brain, the harder it is then to keep searching, and the longer that the brain has been without a blood flow. So that's the difference between those two. So let's talk about aphasia. It is one of the things that can happen after any sort of TBI. It can happen after a stroke or any of the TBIs that we talked about, even certain types of concussion. And like this says, it's often due to stroke, but it can be due to other things too, including the neuroblastoma that I showed you last time. Usually, when we see aphasias, it's going to be on the left side. That's because that's the side, and you probably remember this from when we were talking about speech anatomy, but the left side tends to be your speech side. That's not 100% true in everybody. Left-handers, well, okay, let me jump back. So about 90% of right-handers have their speech hemisphere is their left hemisphere. But then left-handers are weird because for some of them, they use the left hand and the left side of their brain is still the speech hemisphere. But that's about 50%. The other 50%, everything is flipped. So they use their left hand and their brain is essentially backwards. Their language center is on their right side. So when we do fMRI research, like I've got a couple papers published with using fMRI research, you'll see that we only use right-handers. That's because when you use left-handers, your results get kind of funky because you're not sure, is this person flipped or does this person have a brain that's like the right-handers? And you kind of have like a 50-50 shot. So we don't usually use left-handers in those kinds of studies. Anyway, aphasia usually involves damage to the left side, but again, that's not necessarily true. I don't know how prevalent left-handedness is in society. It's not 50%, but let's say it was. If it was 50% and 50% of those left-handers then had their right side be their speech hemisphere, then 75% of people have their speech side on the left. So then you'd expect 25% of aphasia cases actually happen with damage on the right. It's lower than that because it's not 50-50 right versus left-handers. I think it's more like 80-20. So in that case, you're down to like maybe 10% involves damage on the right or less. So it's usually on the left, but it doesn't have to be. What you expect from aphasia, well, again, it differs from person to person. We're going to look at some really good cases that kind of show you a textbook definition of what you expect, but your patients, when you actually get into it, could be slightly different. And that's because, no stroke is exactly in the same place, no TBI is in the same place. Brains are slightly different from person to person. But you do have problems with verbal expression. What's really important to note about this is it's not just speaking. So if you have somebody that has Broca's aphasia and they can't get the words out, you can't just ask them to write it or to type it out. The problem is you feel like you know the word. It's up here somewhere, but that concept won't turn into language. It won't turn into spoken language. It won't turn into written language. It won't turn into typed language. Nothing. So it is problems with verbal expression in general. Not speaking, not just speaking, not just writing, but all communication. And then again, one of these is naming, right? So naming objects. One that I don't think you're going to see in this, no, I don't have the video, is a guy who is trying to describe a scene, like a cartoon. And there's a ladder. And they're asking him, like, how are they getting, the cookies? And he says, they got the Zoom, and he keeps saying Zoom instead of ladder, which when you think about it, it makes sense. You go up it, Zoom. It kind of makes sense. You just can't get anything out but that. And so that's a problem with naming. That one is pretty sad to watch because he is getting like visibly distressed. He knows he can't say the right word. And what keeps coming in is Zoom. And, it gets uncomfortable because you start thinking like, what if, that was happening to you? You know how you want to communicate, but you can't make yourself communicate that way. And it would be extremely distressing. You'll also have people present with deficits in comprehension. So you'll ask them a question, and maybe they'll answer something that's just completely ridiculous. You know, they didn't necessarily understand your question. I have some thoughts about that. Is it... Well, okay, I'm going to save that. I'm going to save what I was going to say until we watch that video. So it could be problems with comprehension. We'll see. And then also you have people that have problems with repetition. Either they have problems repeating what someone has said, or they repeat the same thing quite often. You'll see both in the next things that we talk about. So remember, these are kind of your main three things. Is that you can have deficits in expression, deficits in actually talking and getting your point across. You can have deficits in comprehending, or people talking to you and making sense of the language that they're saying. You can have problems repeating what they've said to you. Okay, so if we think about really quickly, how does a word come out of our head? If you're in 367, this is like... You'll know that this is a really oversimplified look at it. 367, if you're not in it, is language science. And we really dive into how we actually produce words. For this class and for what we're going to talk about, if you have the knowledge from 367, apply it to this. And I think it'll even be more fascinating. If you don't, kind of think about your own process to produce words. So you have an idea. There's an idea up here, right? And then you kind of have to access the concept of the words. You have an idea that's kind of this abstract general thing, and you need to pull the concept of a word. So there we go. So we find something that matches the concept that we want to talk about, right? We have this idea, maybe it pops into our mind of a car. And then you're going to start pulling out words. This says lexicons, which isn't exactly the right idea. Lexicon is you're accessing your lexicon. The lexicon is your internal knowledge. So you're accessing your lexicon to find specific lemmas, is what it should say, that access the concept. If you don't know what a lemma is, it's okay. But it's like the pre-linguistic form of this word. So you have a concept, you access the pre-linguistic form of the word, then you select it and you send it to the motor program, and then you say it. And so you can have problems in any of these areas. If you have a problem here, you can't find the word. This happens when you have tip of the tongue phenomenon, right? It's when you think and there's a word and you think, I just can't, what's the word, right? Like that. You know it and you can't pull it out. So that's what happens. We're accessing our lexicon and it's not coming to us. Sometimes you can have trouble picking the right one. Like you can say synonyms of it. Well, that actually goes with tip of the tongue as well. So when we have that problem, sometimes we can say synonyms and you just still can't pull out the right word. Whoops. All right, so that's mainly the basic things. We're going to talk about different problems in different areas. Okay, so, all right, Broca's area is, we talked about this. It's near your motor strip, in the frontal lobe, at the very back portion of the frontal lobe, and it is typically where language is produced. This is usually where we think about language production, although a lot of recent studies show us that it's also involved in language comprehension. Wernicke's area is an interesting thing because there's a paper that came out, I want to say in 2018, I think it was 2018, that said Wernicke's area doesn't do anything. We think that it's where we comprehend language, but actually when you look at it in a meta-analysis of different meta-analysis is just a bunch of studies put together. The meta-analysis shows that it's not actually involved Whoops. I'm like dripping tea all over myself. The meta-analysis in the Wernicke's area is not actually involved in any of these language processes. That's not to say that we don't have something like a Wernicke's area that's involved in language comprehension. There is some areas here. This is our primary auditory cortex, should be around here. The planum temporal, or the belt region, is about here. Part of that is involved in Wernicke's area. That's involved in comprehension of basic sounds. There's some portions back here in the parietal lobe, at the very tail end of the temporal lobe here. Those are involved in speech recognition as well, and also Broca's area. So here's the deal. Even though there's a lot of research that shows that Wernicke's area isn't involved in things, especially in decoding speech, that is very current research. It hasn't reached the textbooks yet. So when you read your textbooks and other classes that you might have before you become an SLP, or even some of your continuing education classes after, will probably still reference Wernicke's area. So know that it's not necessarily one area that governs word recognition, speech recognition. That's not necessarily true. In fact, it's not true. There's not just one area that does it. There's multiple areas. But when they say Wernicke's area, you're looking for speech recognition. That's what that area means. And eventually, the textbooks will catch up to the current research and agree that there's no one area. But it does make it easy to talk about when we can say Wernicke's area, and really we just mean word recognition, a distributed process. So when I talk about Wernicke's area for the rest of class, I'm talking about a distributed network of areas that are involved in speech recognition and word recognition. Broca's area is a real thing. There's a lot of evidence that shows that it does exactly what we thought it did. And it's mostly involved, again, in production, but it actually is involved in comprehension as well. And also involved in, like sign language. It's very involved in that as well. It's involved in some written language. So it's a really active area. Broca's area is a very important area. The arcuate fasciculus is a neural tract that connects Broca's area and Wernicke's area. Now this shows multiple nodes going from one to the other, and actually a lot of the current studies show that the neural tracts go from Broca's area to different word and speech recognition zones, so it connects to multiple ones. But still, the arcuate fasciculus is going to go from word recognition to word production. Wherever it is, if it's not necessarily Wernicke's area, it goes from word recognition to production up here in Broca's area. So the arcuate fasciculus connects the two. Okay. Yes, we've talked about that. Fluent aphasia is going to be... it's kind of like a word salad type of aphasia. It's very fluent. It adheres to grammatical rules. If you weren't really paying attention, it would sound like the person was talking and making complete sense. This would be with lesions towards the back, towards Wernicke's area. Sometimes it's called Wernicke's aphasia. And that is an interesting one that we'll talk about in a little bit. All of the examples that we have coming up are really good, but there's one example that I have to pull in from YouTube that is the best example of fluent aphasia I think that I've ever seen. So it's not going to be in these slides. It's going to be in this video lecture. I'm going to pull it up, but it'll be a separate video if you want to watch it again. Anyway, we'll see some things that have aspects of fluent aphasia. We'll see things that have aspects of non-fluent aphasia. Non-fluent aphasia is when you can't find the words. And so even if you were kind of not paying attention, you know that the person was having trouble because the words wouldn't come, right? With the other one, it's totally garbage over salad, make it and have more happen, and then it gets all better. like that. So it sounds like they're actually saying something. Non-fluent aphasia, you can tell that there's something going on. And that's associated usually with, well, again, Broca's region, more the production area. Something's wrong with production or selection of the correct words. Again, with fluent aphasia, something is wrong with... It could be that it's like a speech recognition problem. It's possible that maybe they understand that you're asking something, but they're not tagging the right meanings to the words that they hear coming from you. And so then they answer something. They also can't hear necessarily and make sense of what is coming out of their mouth. They're not aware that they have a problem, usually, with fluent aphasia, Wernicke's aphasia. They don't know that there's a problem. Doesn't seem like it. Again, I mean, that's the hard thing. You can't actually ask them these questions because they have a problem with being able to communicate. So we kind of have to guess about what we know about it. It's really interesting. Think about that when we watch, I call him Green Shirt Guy, but when we watch Green Shirt Guy, think about, does he understand what she's saying? We'll talk about it again. Never mind. We'll talk about it when we get there. And then Broca's area, this is a problem. You know that you're having an issue because the words won't come to you and you can't find the right word. So this is an example of Broca's aphasia.
Can you show me how you'd make a peanut butter and jelly sandwich?
No.
Open the jar, put it on the bread. Okay. Put them back together again. Can you show me?
Okay, so what you saw there, whoa, I adjusted my volume and it's too loud. Sorry about that. So what you saw there was this guy has a problem with being able to communicate. He's got Broca's aphasia. The words won't come. But what we do see here is that he's extremely capable at showing the person who's with him. I'm not sure. I assume it's the therapist who's with him. Although somebody I was watching this with said it's his wife who the therapist is having ask these things. I think it's the therapist. Anyway, so he's really good at showing how to make a peanut butter and jelly sandwich. But in terms of saying it, it doesn't work. These are there, and they're cues, to him. He can show, like, the cue is here. It's not a language process what he's doing. So he can understand the question. That's great. But he can't answer it verbally, right? So we see that he can't produce the language, that's impaired. But what's going on with my... There we go. Comprehension, really good. He understands what she's asking. He shows what needs to be there. Repetition, we didn't actually see that, but it is impaired. When you have Broca's aphasia, if you say the word that they're looking for, they know that's the word. So the guy that's looking for ladder, you say ladder, and they'll go, yes. And then you say it, and then it won't happen. You say ladder, yes. Okay, you say it. And it might not come. This, again, depends on the person. I'm going to show you another guy who is on a cruise for an aphasia cruise. And he has his wife helping him, but she'll say the word and he'll then repeat it. So it's not necessarily true for everybody. But again, like I keep saying, We have some general truths to different kinds of aphasias, but you're not going to hardly ever find someone who fits exactly the textbook definition. Okay, so here is a good example. It's a good example of Wernicke's aphasia, but when we get to green shirt guy, it is so textbook.
Now, tell me as much of the story of Cinderella as you can. Tell me the story. What happens?
She says how to do with her. Then the kins of them do that. Bad things, on the things, take the thing, bang, to do it, bad, bad, bad. After thing, little thing, bing, 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 a thing of this. The other one can see it on the thing. They went for, they can looking for, with the big one or things, a good one that says, oh, you can do it. When do you go? See a good letter to do it, boom, 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 boom. She sees it. The ball ones we want it, we like them, we're going to get it. It says, oh, I got to go, it's going to go. Fit it back, launch the thing on, gone, lost of it. One here from looking of it. Put down the bad thing with something, it shot it, she saw it. I don't remember that one. But when you say it, she'll be looking to get it. The bin one would say no of it. No, I can't see it. The next one, you can't see the two ones do it. They should be doing it, so not doing it. It should be the one guy is doing this. The two guys, well, I should do it. I can't get it. Can't get it. Now she says, well, I'll try to. I could get it. It's me, the big one. Now he's going to tell the one, you get the matter away, gang away, back again. Am I saying it?
Yeah. And then what happened? What's the ending?
She got it. Another thing, you get it right here.
Okay, so that's Cinderella. And because we know the story of Cinderella, I could pretty much follow along with what he was saying, right? I mean, there were elements that made sense. The hand gestures were right. Like he did a magic wand at some point. That was good. And then the part that I was kind of getting a little bit lost on was the one can't do it, and then there's two and they can't do it. And then when he did it won't work, and then it won't work. I think that's the shoe, right? It's putting the shoe on the foot for Cinderella, and then he puts it on, the prince puts it on Cinderella. You know the story. Now I sound like I have aphasia, but anyway, you do know. You hopefully you know the story. If you do, you can kind of follow along. But if you didn't know the story, this would be, nearly meaningless to you. We know it because we can kind of fill in. We're the familiar listener because we know the story. We can fill in what he's trying to say. If you didn't know the story, it's all gone, right? There's not really a lot of, there's no, exact nouns. There's no, a lot of the concepts just aren't there. And so that is pretty good with Wernicke's aphasia. The green shirt guy, the only reason why I like him better is he is even less, you can't even tell where he is going. It's even more impaired. Now, this guy, it seems like he might kind of know that he's not saying it right because he asks, like, am I saying that right? It's possible. But I'm wondering if he's only getting that from his past experience with other people, maybe in his family, at a job or something. They have no idea what he's trying to say, so he knows to ask if you're understanding. But he can't tell that he's not saying it right. He can't tell that like 90% of what he's saying is thing. It's really, really strange. But then another thing that was really interesting, which I'm sure you noticed as well, was there were surprising moments of clarity, like probably words and phrases that he said very often. Oh, I gotta go. Was perfect, right? It's almost midnight. So, oh, I gotta go. What was the other thing? There's one other thing that he said. You can do it, or something like that. That was pretty good. And then it went back to just the thing. And he's not really aware that there are these deficits. So, the comprehension, our comprehension of what he's saying is not good. Repetition. Again, this wasn't on. We didn't see this, but it would be impaired as well, because he would say a word, and then he might just say, "Oh, the thing." And I don't know what. Oh, it's cookies. Oh, it's one of those Christmas tins of cookies, because it says season's greetings. I understand now. I've seen this video so many times, and it looks like a giant cat food container. And now I understand it's a small thing of cookies. All right, well, cool. Now I want cookies. All right, let's take a look at conduction aphasia. Remember, this is the that arcuate fasciculus between the Broca's area and the Wernicke's area. This is going to have, well, I'll let you figure out what you think it has.
The mouse, there's mouse, there's a pumpkin, and the mice are horses now, and the pumpkin, there's a carriage or something, and then they go to a ball, and that's why the prince, they went to a date or something. So they went to a ball, and I think she had the time. So she has to go back home, and now it's gone. It's stopped. The pumpkin's gone. The horses are gone. She's back home. And then I think the end, I forgot. Either the prince, she take him out or somewhere out, and now they're good. Happy something, yeah. Okay. House.
Spool, belt, flower. Should I go on?
Yeah.
Okay. Candle, hand, saw.
Candle, gone, and gone.
Okay, so this is an interesting one, right? What we've got is production, I'd say, is pretty good, right? He's definitely better at telling us about Cinderella than the second guy, the guy that we just saw. He used a lot of, specific words. The first guy wouldn't have been able to basically tell us anything. It seemed like there was almost no verbal ability there at all. The comprehension of what he was saying was, good. He's able to understand the question, tell me about Cinderella. He gets it. But then where we have the problem is with repetition. So now with the guy that we just saw, repetition, The reason why he would have a problem with repetition, and again, you didn't see all these videos for them because it's not the thing that stands out most. The reason why the guy just before would have a problem with repetition is you'd say camel and he would say thing, and he would assume that it seems like he thinks that he's getting it right, so he says thing. To him, he's saying camel, which is so strange. There's a problem with the selection of the concept and the selection of the word to go to the motor program. There's a disconnect there. Now the problem with the first guy is you could say camel and that word wouldn't necessarily come out. There's not a lot of words that can make it out for him. You could tell that there wasn't an impairment in the actual structure of anything because he could mime eating, he could laugh just fine, so the vocal cords are intact. There's no problem with the musculature. It really was just the ability to speak words that's impaired in that case. Now for this guy, he can do both of those things. He can tell us about the story with good information. He can... both of those. He can actually tell us, and he can tell us with actual words. But then when you try to have him repeat what you've just said, right? So what did she say? Candle, hand, and saw. I mean, I would think that everybody in the class, candle, hand, saw, you can say back to me, candle, hand, saw. Right, and I remembered what she said even after going through all this, which I'm sure you could too. You probably remembered exactly what she said before I brought it up too. It's typical, but it was gone for him almost immediately. Candle was all he had, and then it was gone. So he's got really good comprehension. He's got really good production. Well, decent comprehension, decent production, but the repetition is completely impaired. Okay, so let's take a look at this one.
Thinking back, can you tell me a story about something important that happened to you in your life? It could be happy, sad, from any time, from when you were a child or more recently.
My daughter, no, my son was born, and then my daughter was born. Golly, I can't tell you how happy I was. But, okay. See, Robbie, he was 1 year old when he had his first seizure. And every time after that, he was more and more acceptable to the seizure. And golly, okay, 4 years old, he freaks out them. But he's so smart. He's go to in high school. He goes to I don't know.
Food, sock, night, thumb.
Food, sock, night, thumb.
Food, sock.
Okay, so this one is interesting. There are two. I think there's two things going on here. So what we want to look at is transcortical motor aphasia. You can see here the motor strip runs from about here down through this region down to here. Broca's area is right about here, and the rest of the motor strip is here. Now, the fact that her deficit is on the motor strip, you can tell that there's something wrong, that the speech is effortful. It's not, it doesn't flow super well. And that's really what we're looking for with transcortical motor aphasia, is this kind of disordered speech, effortful speech. You might have heard about people who go to sleep and they wake up with accents and they can't not talk in that accent. There is really good evidence that what's going on there is that they've had a small stroke in this motor area, and what's happening is it's changed the motor program. The muscles are fine, the mouth is fine, everything moves right. It's the message coming from the brain to the muscles that has changed. And sometimes what happens is you can have a very small stroke in this area and it can come out sounding like an accent. It sounds a bit like she has an accent, although hers is bad enough that you can also tell that, that there's some effortful speech going on. Now, I said that it seems like there's two things happening, and I do. This is very close to Broca's area. Broca's area produces Broca's aphasia, or non-fluent aphasia. It also seems like she has a hard time pulling the right words out. So it's not just that she's got transcortical motor aphasia. She's also got a little bit of Broca's production aphasia in there as well, I think. Now, something that was really, really interesting to me was the fact that she can say golly and I don't know super well, and almost without an accent, without the strange, we're going to call it an accent, it's not, but without the muscular problem, without the motor problems, without the accent. Did you hear the I don't know? I played it twice because it was so bizarre. Let's do it one more time.
Beta, ICD.
Okay, so there's an example of,
I don't know.
shoot.
In high school, he goes to I don't know.
Right? That's so crazy. That comes out perfectly. And that makes sense, actually. Remember what I said about one of the other guys, the guy that was telling us about Cinderella? You've got these things that you have learned how to say so well. The concept, the motor program, the words that go along with I don't know are almost a reflex. When your brain goes, boop, error, you've learned to say, I don't know, right? And so this is like almost a different area where the speech is produced because it goes along with almost more like with a feeling than actually with a speaking thing. So that can come out okay. The other guy, oh, I gotta go. Probably something that he used to say a lot. It comes out of somewhere else. It's a feeling of I'm late or have to go or something like that. So these things can pop out and they're very fluent. And it didn't sound like she even had the motor problem when she said that. Probably because it might be coming from a slightly different area. It's not speech that she has to pull out and construct. It's coming from somewhere else. I think we've got one more to look at. Well, let's take a look at what's going on with her. So the production is impaired. comprehension is intact, and repetition is intact as well. She totally knew the words that were coming out. It seemed like she only had a problem making, producing the words because of the motor problem. So here's our, I believe, last one.
Okay. Tell me the story of Cinderella in your own words, and you can use anything you know about Cinderella besides what was in this book.
Cinderella was a beautiful, beautiful girl, and she was introduced as given a job to a beautiful camp. A camp that was not beautiful of the girls, kind of hard, mean, but she was everything about her and the way she did was beautiful. The way she did the house, the way she did the tray, everything was beautiful. And then one day, she looked outside and she saw the beautiful, beautiful field. Oh, she could hardly believe the satin feel of it and the the orchestra. And she thought, I wonder what it's like there. And she found that it was truly wonderful that there, of all people that she met, they were costume, everything beautiful, she met the man. He was a gorgeous man. And she gets committed to him, and she ends up marrying him. And she's playfully, wonderfully well.
The dog chased the cat up the tree.
The dog chased the cat up the tree.
The bird was caught by the worm.
The bird was caught by the worm.
Would you like to star in a movie?
Would you like to star in a movie?
Books like to read children.
Books like to read children.
Okay, so her repetition is pretty much perfect, right? In fact, that last sentence, books like to read children, that's in there as kind of as a test. So if somebody's doing really good with repetition, they'll throw something like that in, because what you'll see, some people can repeat really well if the sentence makes sense. And then you'll change the thing around so it's a completely nonsensical sentence, and they might not be able to say it well. But with this one, she said it just fine. Books like to read children. She got all the way through that really well. So the problem, which I'm sure you heard with the story, was everything was beautiful. Some of the story didn't really make sense. It kind of seemed like maybe she got kind of off track by saying beautiful. It went into orchestra and satin something and a hill, and I wasn't totally sure that I followed necessarily all of it. What's interesting is it's more understandable than the Wernicke's aphasia, although it's close to that, right? There's some elements that seem very similar to Wernicke's aphasia, except that it's not, there wasn't just thing, like the one guy was saying, and it's not just word salad like you'll see in a minute. There was some sort of story going on there, but there was definitely a problem with the meaning, right? There was a problem with the meaning of the words, and she seemed to get sidetracked in her own story based off of maybe pulling synonyms for beautiful, right? And she kind of got stuck into that. And that's kind of where the transcortical sensory aphasia comes in. It's a little bit more of a cognitive, I mean, they're all cognitive, right? So, I mean, it's a higher step in the process is what I'm trying to say, right? So, Broca's aphasia is you're at the level of you can feel the word, you know where the word is, and you can't make the connection to that motor program or to the selection of the word, but you know the word. This is somehow upstream in terms of actually selecting the words. The wrong word is getting selected, and the brain seems to be going kind of in a loop based off of maybe the semantic network that's constructed around some phrases or words or ideas. And so then the story gets a little bit garbled. This one, I think, is always a little bit harder to understand. It's also harder to differentiate, like I said, from Wernicke's aphasia. So again, the comprehension is impaired. Her comprehension of the story is impaired, but it might not necessarily be that her concept of it is impaired. It might be that what's coming out, it seems like it's gotten into a loop, and then that's what comes out. It's hard to know. But repetition is great. Okay, I guess I was wrong. So here's a global aphasia. This one is, we're not going to be able to kind of, well, you'll see.
How about her? You know exactly who she is. She's going to guess that you know. Singing is a great way to do this.
Is it Judy Garland?
Beautiful. Wonderful. I know you know. Don't need to ask it before whether she's Judy Garland. How about these guys? Not their individual names, but... how about... Four of them. And they're singers. We know that. Good start. Are they the Rolling Stones? Yes or no? Is that yes or no? Okay, you don't know. Okay. Is one of them named Ringo? Yes, one's named Ringo. Are they the Beatles? Just take a chance. They either are or they aren't. Are they the Beatles or aren't they? They are the Beatles. Yeah, they're the Beatles. How about her? Yes, she did sing. Was she married to Joe DiMaggio? Take a guess. Yes or no? Maybe? Maybe. Is there... Okay. Is her name Carol Lombard? Marilyn Monroe. That's correct.
Man, so that one really shows you how frustrating I think it would be to have this problem. So what you can see here, global aphasia, we really can't pin it down as any of them. There's so many deficits. There's it seems like there could be a lack of comprehension. Sometimes not all the questions that she's asking him does he get. Certainly production is impaired. Although it seemed to me like there seemed to be some sort of reason that he's chosen, that there were certain sounds that he was making that were specific for the Beatles versus this last lady. Of course, they're choosing celebrities that we don't necessarily know. I mean, we know the Beatles, but the other two, certainly Carol Lombard, I have not even heard of. There were some different sounds that he was using, right, in different body language. So it seemed like there was something that he was trying to get out. It definitely seemed like there was some information that was being activated in the brain somewhere, and it just wasn't being able to come out. You can see how frustrated he was getting with his own inability to get some sort of information out. But anyway, like I said, it seemed like there is possibly motor issues. It seems like there's possibly production. Well, there's definitely production issues. There's definitely comprehension issues, and that's why it's global aphasia. The problems are similar to all of the aphasias that we've looked at. So everything's impaired. So here is a summary. Take a look at this, during your studying for the exams. This is a really good slide, and you can go back through and watch any of those videos. We've talked about TBI, so I'm going to jump over all of this, including that. And let's really quickly talk about... oh, wait. We've talked about this too. Okay. There's a little bit more here that we will get into, but we'll kind of go very quickly. So some of the things that we want to look at when we're looking for TBI, when we're assessing TBI, like we talked about, is confusion, working memory, etc. Some of the tests, though, it's not just working memory. Some are long-term memory, so things that should be pretty well embedded in memory. Some things are recent memory, and then some things are working memory. So recent memory, like it says here, is like, what did you eat? I mean, long-term memory, what is your name? What year is it? What's your address? Stuff like that. Recent memory is like, how did you get here today? What did you eat for breakfast? What did you have for lunch? Any of those things, recent memory. So you've got long-term, you've got short-term, you've got working memory. There's some there's some models of working memory that show that these may all be part of the same system. There's some models that think that they're parts of completely different systems. But they definitely work possibly differently. Even if they're part of the same system, one is an activated subset of the other. So there's something else going on. And that's why we test all of them. But the one that is a little bit more sensitive is working memory. You can have somebody that their long-term and short-term memory are intact, but some damage is going on with the working memory. Now, working memory may be, a lot of people who work with it think that it may just be synonymous with attention. And that's why I want to jump back a slide and show that attention is one of the things we look at too. So ability to maintain focus on some things, different types of attention, responding to do two different things, or remaining focused. This is all testing attention. But, like I said, working memory may be attention. It could be that you're placing attention on one thing and holding another thing in, sub-selected in attention while directing your attention over here, but the working memory portion is still sort of activated, and then you can come back to it. And that's why working memory is so good to test for TBI. Okay, so then after this is just going into trying out working memory. So we can do that really quickly. Let's go ahead and do this. So you're going to remember these, and then you're going to write them down backwards. Whoop. I thought there were 5 numbers. I'm sorry about that. I ruined that one for you. So if you're writing them down backwards, it should be 4, 9, 7. Now, the next one, what I want you to do is remember these numbers, then write them in order. Okay, go ahead and write those numbers in order, numerical order. And did you have, aside from the 0, which I didn't show you, you should have had 2, 3, 4, 6, 9. That is one way to test working memory. Of course, you know the other one that we've talked about before, which is I give you a number, or I'll give you a letter, J. What is 3 plus 2 equals 6? No. Okay, now remember Q. And so that's another way to test working memory. All right, that's the end of this lecture. It's also the end of talking about TBI. We have one more lecture to go that I might break up into a couple different ones, but we're going to talk about speech science.